Hi, class. We are starting the lecture on Chapter 6, Assessment and Intervention. Back in one of the last lectures that I did, I think I mentioned to you a friend of mine who had a stroke when he was in his early 40s, and I think it was when we were doing feeding and swallowing, and I told you about going with his wife. Well, um, he had that stroke, I want to say it's a good 10 years ago, maybe 15. And on Valentine's Day of the year that he had that stroke, he sent out an email, and it might have even been a Facebook post. And it had been about a month, I think, since he'd had the stroke. And I put it at the top of these lecture notes. It happened to be near Valentine's Day when I was doing this chapter in a spring semester, and I've read it to every class ever since because for a couple reasons. One, it's a little glimpse of you'll see the language issue that he's still having. This is a very articulate, very well read man, um, and you'll see how simple his language is. And there's one error in his language, but I also just do it kind of as a way to honor him and what he went through, and to remind me and everyone else that life is short and you need to enjoy the moments. So I'm going to read you it's very short, little 2 or 3 sentence message. It says, "Today is first since my stroke on February 14th. Oh, he had the stroke on February 14th. That's right. So this is about a month later. It's good to be back and see my friends. Please be patient with me. I have much more therapy to do left. Things are getting better. Thank you for the prayers and support of my family." So that's for you, Scott. All right, Chapter 6, Assessment and Intervention. I'm sure I've said this before, but assessment has always been my favorite part of my job. So it's what I do full time now. I'm not doing therapy at the moment, but even when throughout my whole career, assessment has been my favorite part of the job. It is solving a puzzle to me. It's unlocking what it is that's getting in the way of someone's effective communication. So I really do love assessment. The chapter, so I will try not to get on soapboxes, but just beware, I can do that with the conversation about assessment. The chapter begins with a discussion of evidence-based practice. We're going to come back to that in a bit. We're not going to start there. So we're going to jump in and just talk about assessment in general. We're going to talk very broadly about both assessment and intervention. Some of this information we have covered already or alluded to in other chapters. So please, please, please make sure that you read this chapter thoroughly. Don't skip over things that sound like it's something you've already read or already heard. I've posted a definitions list or a list of terms for you on titanium, so please make sure you look at those. Some of those are incomplete. It's just the term. But remember that if I've taken the time to put that together and to post it to you, I need you to have familiarity with those terms. Even the ones that I don't define for you, I will either define them in the lectures or it's right there in the book. But just know those are important terms for you to understand. So assessment is a comprehensive process of gathering information regarding one or more of the areas of speech language science. So the areas we have already covered and some that we will cover in the next few weeks. So speech, language, voice fluency, cognition, feeding, swallowing, and or hearing. Assessment is the way of gathering information in one or more of those areas. It is most often a multidisciplinary process, so meaning that it involves other related professionals. In the very least, it's going to involve perhaps a nurse to do a health assessment, or a family member to contribute information. On the other end of that involvement, you could be, as an SLP, part of a full multidisciplinary team, sort of like we talked about with children with cleft palate or cerebral palsy. There are big medical teams involved in that process, or in feeding and swallowing disorders. Assessment needs to be accomplished in a very systematic way so that the outcome will be comprehensive and non biased and valid. And we'll talk about what all of those terms mean or what they imply in the area of assessment. There are 4 purposes of assessment, and this is in your book on page 172. It's table 6.1. So, what I'm going to do is give you the 4 purposes, and underneath each purpose, I'll tell you what it is the question that we're answering based on that purpose. So, the first one is to identify skills or lack of skills in a particular area of communication. So, the question here that we're answering is, are the skills that we're seeing consistent with disorder, or do they line up with what we know is average ability or average development? So we're making that distinction. Is this a disorder? Sometimes in education world, we call it a handicapping condition. Or is this average ability, average development? So that's our first purpose, to identify whether or not those skills are consistent with disorder or disability. The second is to guide the design of intervention so that we can enhance a person's skills in a particular area of communication. So again, the question that we're answering here is, what are the appropriate goals and objectives? What are the appropriate strategies and contexts in order to best address this person's unique needs in the area of communication? The third purpose is to monitor a person's communicative growth and performance over time. So the question we're answering here is intervention being effective in meeting the proposed goals? Or are the skills being maintained after we've discharged a client? So there are times after discharge, maybe 3 months down the line, maybe 6 months, you have the client come back in for progress monitoring, just to see if they're maintaining skills or continuing to make self-progress. And then the fourth purpose of assessment is to qualify a person for special services or for therapy, for intervention. So we're answering the question, does this individual's performance meet the qualifying standards for services from a particular governing organization or institution? So in public school world, those governing organizations are your state education code guidelines. So does the person that we're testing meet the guidelines for intervention through the public schools based on, in our state, California Education Code? If you're in a medical setting, that might be, does this person's level of skill or level of disability, does it meet the particular standards for medical insurance coverage? Now, we talked about this briefly before, that a person perhaps coming to you for accent reduction or diction coaching, those should never, ever, ever be billed to a medical insurance. That person is not exhibiting a disorder. Are you still the most trained person to work on those things? Yes, you are. But you should never be billing them to medical insurance, and the person should never be receiving services under the impression that their insurance just isn't covering it, but they are disabled in some way. That is completely unethical. So part of our assessment process is to say, yes, you do qualify for coverage based on the California education codes or under medical insurance guidelines, or to say, you don't meet those things, you can pay out of pocket for services, but because you don't meet those guidelines, I can't say that a disability exists, or even further, there is no disability. For example, in the case of someone with accent reduction, and so we just don't even have that conversation about medical insurance because it's unethical and irrelevant. So we went over the 4 purposes of assessment. Then we have the assessment process. What actually is involved in this process? This is on page 173 in your book, figure 6.2. The first step of any assessment, you've heard this before, is screening, and then referral is tied in with that screening process. Again, screening is just a snapshot of an individual's performance in a particular area. It is very helpful in some situations. We talked about with the swallowing and feeding, doing bedside screening, the beginning of assessment for swallowing issues. Screening is very helpful for hearing assessments. Screening is what you had done when you were in public school and the nurse came in and did screening or did hearing assessments with you. It can be very helpful for voice situations. It can be helpful in the area of speech and language as well. I don't mean to imply that it's not helpful. It's just that, again, in public schools, screening is a form of assessment that requires parent consent. So if you're working in the schools and a teacher says, "Can you just screen this child? Can you come into my class and listen to him? Or can I send him to your office and you just take a listen and tell me whether you think he needs assessment?" The answer is no. I can't do that without parent consent. And if any of you want to have a conversation about why that is or what that looks like, what you would do in that situation, I'm happy to address that at another time. I don't want to take our time with that. But just know that screening isn't something that should be routinely being done in public schools. As part of that screening, so still step one here, is then the referral process. Referral is the formal process of initiating that communication-based assessment. So that referral can be a result of the screening. That can be you're making your own referral of this person to additional assessment, or the referral can come from any number of different sources. Most commonly, it comes from physicians or nurses, home health workers, teachers, parents. Okay, moving on to the second part of the assessment process, The second part of the process is designing and administering the assessment protocol. This really is the bulk of the assessment. And we're going to cover a number of points here. Assessments should be highly individualized for each client. We're going to come back to what that means. They must be sensitive to the suspected area of disability. They must be comprehensive. Thorough would be the synonym for that. And they must be non-biased. And in a perfect world, they are family-centered. So we're going to break all of those down. I think in your PowerPoint, I gave you four bullet points for this, and there's really 5. So I apologize for that. So we're going to start with that highly individualized piece. Highly individualized means that we are developing an assessment protocol or putting together the pieces of this assessment based on the person sitting in front of us and what our thought is about what we need to be looking at. It needs to be individualized to that person. So, for example, I have seen reports from school districts and have talked with people from other school districts and from medical institutions, it's not just school districts, where the management has said, okay, we will buy the Clinical Evaluation of Language Fundamentals. It's a big comprehensive language test. We'll buy the Peabody Picture Vocabulary Test, and we'll buy the Goldman-Fristow Test of Articulation, and you need to use those for every person that walks in the door. We're not buying any other materials. Well, that's not meeting this standard of highly individualized, because those tests might not identify what we need to know in a very specific way to best design intervention for this person or to best diagnose this person. So you just need to know they need to be highly individualized. If you suspect this person has short-term memory issues of any kind, you need to pick out specific kinds of tests. If you suspect that there's some kind of vision impairment with this person, you need to pick out very specific kinds of language tests that don't require a lot of visual responses or a lot of visual scanning. If you suspect hearing is an issue with this person, you pick different tests. So it needs to be very individualized to the person in front of you. Okay, then the rest of this definition. It must be sensitive, comprehensive, and non-biased and family-centered. So let's talk about each of those. Sensitive. We're answering the question with sensitive. Will this test instrument we're using or this test protocol we've developed, will it accurately identify whether a problem is present? And will it help us characterize its severity? Is it sensitive enough to do that? Now, the answer to that, and I'll say this again when we talk about another point, is for most individual tests, the answer to that is no. We need to have additional information. But we still want to pick those individual tests in a way that they are as sensitive as possible to help us identify whether or not we are looking at an area of disability or not. The second piece is it comprehensive? The question we're answering here is, does it accurately identify all dimensions of the problem? What that is referring to is, does our assessment that we're designing, will it help us with understanding the person's needs in their daily living situation, in maybe their workplace or in a school-based environment? Are we identifying what their needs are within all of those spaces that they need to communicate? So is it comprehensive enough? Is it non-biased? Is this an accurate characterization of a person's communicative ability that considers the influence of race, of ethnicity, of gender, of socioeconomic background, of culture or native language? So we need to be testing in a very non-biased way and take those things into consideration. And then, is it family-centered? And I said in a perfect world, because we don't always get this opportunity, but at the most, the best we can, we need to have family members involved in part of the assessment process to share their understanding about this person's strengths and weaknesses, what the family's priorities are, what the family values are. And by values, I mean the things that they value, how this individual's communication abilities impact the family and their ability to communicate with each other. So I'm going to read you a paragraph that I include in all of my reports. So if you're taking notes, you can stop taking notes right now. I just want you to listen to this, because our reports need to reflect that we have considered all of this. So this is the big, complicated, jargon-loaded paragraph that goes in all of my reports. So hang on with me here. I'm just going to read it. Sophia's primary language, racial, and ethnic background was considered prior to the selection and interpretations of evaluation procedures and measures. The testing and assessment materials and procedures used for this assessment were selected and administered so as not to be racially, culturally, or sexually discriminatory. The tests and other assessment materials have been validated for the specific purpose for which they were used and were administered in conformance with the instruction for the test or other assessment materials, unless utilized in an alternative manner as noted. The tests and other assessment materials include those tailored to assess specific areas of educational need, in my case. No single procedure was used to determine Sophia's eligibility for special education and/or determine appropriate educational programming. A language assessment was carried out in English, as this is Sophia's only language. Test selection did not affect the validity of the assessment, nor did the result of Sophia's performance appear to be a consequence of cultural differences, environmental variables, or economic disadvantage. Tests were valid for their intended purpose and should only be interpreted within their intended limits. Now, that's a whole lot of jargon, a whole lot of information, but it's also a whole lot of legal information that could be challenged if my assessment then was not as described in that paragraph. It needs to be culturally unbiased. It needs to be sexually unbiased. It needs to be unbiased in terms of the materials that I chose. They need to be specific to Sophia. Now, I did an assessment on a little 4-year-old last Friday who is not a monolingual English speaker. In fact, in his home, English is the primary language because mom and dad have 2 different languages. Dad speaks Chinese, mom speaks Vietnamese. So in order for everyone to be able to communicate, they use English only among the 3 of them, even when dad and mom are communicating just to each other. So truly, English is his primary language. However, he is also exposed to Chinese and Vietnamese when extended family members are in the home. And grandma, I believe dad said, does live with them, one of the grandmas. So Also, as part of a paragraph like this, I would include that information that although the primary language reported was English, and why that was reported that way, the child was exposed to other languages in the home and therefore may be impacted by the influence of those languages. So, all right, moving ahead. We're still in part 2, this assessment, and what does it include? Sorry, I have to log back in. Okay, so the first part of this formal part of the assessment is the chart review. Chart review is the term used in your book. In education world, we would call that a record review, but same thing, chart review. This is a systematic examination of an individual's developmental, medical, or educational history as it has been collected by other professionals. So you are opening up a chart or a record on a new client and you're reviewing it. There's nothing in there that you wrote. You're looking at the medical and developmental history that might be in there. You're looking at any notes from other providers that they've taken recently. You're looking for old assessment reports that might be included in the records. This allows you access to other practitioners' opinions, their diagnoses, any, again, as I said, prior assessment results, records of any previous interventions, progress notes. So again, in a hospital setting, a clinical setting, we would probably call these chart reviews. In the school setting, we're going to call them record reviews. The next part of this assessment is an interview, case history. We've talked about this ad nauseum in other chapters. We're going to do the same kind of thing here. It's going to be specific to the area of disability we're looking for, right? We want to interview either the person or a caregiver to collect information about medical history, developmental history. Again, if it's swallowing, it's a different kind of interview. Just depends on the area of disorder, but I'm not going to go into all the details of that. The next piece of assessment should always include some systematic observation. This is observation of the patient's language and speech abilities. We're going to stick with language and speech. Swallowing is its own kind of thing. Language and speech abilities in a natural context. So we just want to observe how this person communicates with people around them. So in schools, I might go into a classroom and watch the child participating in the classroom, or I might go out onto the playground. Another piece of assessment, and this is, remember, the first two, the history piece, and that's with every assessment. Observation should happen with every assessment to some degree. Then here are other pieces that we can pick and choose from, most of which we do choose, but in the assessment. The next is questionnaires or surveys. These are formal mechanisms for gathering information about a particular topic. So these can be things like self-rating scales for voice or fluency or even articulation. I want you to kind of veer out of child world, although we could use these with a little bit older kids, certainly. But a self-rating scale. So finding out how they feel about their speech or language skills. Mostly this would be speech, so articulation, fluency, and voice. They could be rating scales that we give to parents or caregivers or teachers. So looking at things like social skills or our pragmatic language skills. We would also give those kind of scales for stuttering assessments to parents and to teachers. There are formal rating scales for ADD, ADHD, and autism that we give to, again, parents or teachers. So those are questionnaires and survey kind of assessments. And then we get to what we call the formal testing. This is formal, commercially developed tests that are given in a highly standardized manner. And we'll come back to what that means much more specifically a little bit later. But in general, what it means is that the test is given in a highly specific and uniform or scripted way so that its administration does not influence the individual's performance. So to put that in really common terms, no giving hints, right? You're giving this assessment. You are not saying anything that would provide extra information to this client, but not this client. It's very scripted, and these will make up the bulk of your assessment. And we'll come back to what standardized testing is in a bit. So formal testing. And then instrumentation can be part of assessment. It isn't always, it just depends on the setting you're in and the kind of assessment you're doing. Instrumentation allows an online, or not online like the computer, online meaning real time, examination of performance. So these are performance as it's happening. So these are things like that barium swallow study we talked about back in the chapter on feeding and swallowing, or examination of the vocal folds via some video x-ray while a person is talking, or brain imaging while language processing is happening. All right, jumping ahead, we'll come next to page 184, but I'm going to stop us right there and we'll continue on a second video.